Continuous care is something that can be added to care when you're in your residence and you need a more acute intervention. And that has to be, the need has to be for a nurse or nursing services for at least 8 hours a day, but can go up to 24 hours a day during a time of crisis. The main reason is to provide pain and symptom management. And once that gets under control, then we won't be paid for that level of care any longer, and they revert back to routine home care. So you might seek continuous care again if the patient's at home or in a nursing home or in a residential care facility. Then there's the level of, and we're paid hourly for continuous care, only for the care and the number of hours that we provide. Inpatient care, there's two types of inpatient care. There's inpatient care that's listed here where it's more of the acute intervention. The pain and symptoms, again, are out of control. We find that it would be easiest to get those managed, not at home necessarily with continuous care, but bringing the patient in to either a hospice inpatient unit, a hospital where we have inpatient contracts, or a nursing home where we have inpatient contracts where there's a higher level of care and we can help manage those symptoms. And there's respite care. In this case, respite care is provided for a maximum of up to 5 days, and it's to give the family a rest. Sometimes the caregiving has been going on for some time before hospice gets involved, and the family members that are doing it are exhausted. And this allows us to bring the patient in for up to 5 days of care while the family gets the needed rest that they need, or maybe they have to be at a graduation of their daughter across the state and they need a weekend in order to do so. That allows us to give that break to the family and provide the excellent hospice care in an inpatient setting. So how does a patient go on or come off hospice? Well, I already mentioned in order to come on, we need to have 2 physicians that certify that the patient would be likely to die within 6 months if the disease kind of followed its normal course and progress. And the patient has to elect hospice. It's an elective benefit under Medicare. But patients can also what we call revoke hospice. They can say, okay, I think I want to go back to curative care. They can decide, well, I don't want any care right now. They can always sign off hospice at any given time. They contact the hospice, they sign a form, and everything is turned back to normal with their Medicare coverage. They can be readmitted any time in the future, and that's what's wonderful about an unlimited benefit. They don't use up so many days and now have so many few left remaining when they decide it's time to come back to hospice. They can live longer than 6 months on hospice. A lot of people, we get patients that'll say, well, I've been with you for 4 months now, so I think I better revoke so that I save my last 2 months for when I really need it. And we giggle a little bit because it's a confusing benefit and say that's not necessary. If your physician still feels that you could, die in 6 months, then you still qualify, and it is an unlimited benefit. But there are times when our patients' symptoms get controlled, they start feeling better, there's no longer any kind of downward slope in their capacity, and they're getting up and they're starting to say, well, I think I want to plan a trip. We know then probably that hospice is no longer appropriate, and the physicians may not be able to certify that that patient could easily die within a 6 months time frame. We call those hospice graduates. And we gladly discharge patients for these reasons, knowing that we're here whenever, if ever, they need to come back and get our care. Well, there's a few interesting things that happen in healthcare reform. There's a lot of people at odds or very excited about this. Well, we have, hospice was involved in healthcare reform, and there's quite a few things that impact us. So I thought I'd take a little bit of time just to kind of bring you up to date. And that was the HR 3590, the Patient Protection and Affordable Care Act, that they're now calling PPACA. Everything has to have an acronym, I guess. Well, there's a few things that happen. First of all, they're going to have a Medicare Hospice Concurrent Care Demonstration Project. And what that will mean is that people that are at the end stage of their life in 15 demonstration sites will not have to choose between active treatment and hospice. they can actually have both at the same time. And Medicare is going to see, well, is there still a cost savings? Or was the care, the quality of life better in this instance? Let's see what happens when we bring both of those aspects together. That's a demonstration project. Well, there also is going to be a curative and palliative care kind of marriage for children in a concurrent care model for kids on Medicaid and in CHIP. And this is going to happen. It's not a demonstration project. They have found that it's very difficult for a parent to say, okay, I'm ready to stop a treatment. But if hospice can get involved further upstream and talk with them, if we can all have a conversation and they can establish relationships, they're able to hear what potential outcomes of treatments are. They're able to say, okay, I still want it, or no, it's time for me to stop that treatment for these reasons and make that decision. So now, as soon as the Centers for Medicare and Medicaid Services can figure out how to implement this, there will be this concurrent care for our pediatric patients on Medicaid and with the CHIP program. CMS also wanted to make sure that as part of the healthcare reform package, there was quality reporting that was going to occur with hospice. Nursing homes have to do MDS's forms, minimum data sets, they have to complete those. Home health care providers have to do an OASIS form and submit it. Hospice will have to do the same things. And we are currently testing some outcomes of healthcare in the hospice industry. Many hospices, including our hospice, we've been doing quality measurement for some time now. So we're actually excited about moving this forward, and eventually it'll be published so that individuals can look up and kind of compare hospices when they're making these decisions and look at what kind of quality ratings different hospices have. And then finally, we're looking at some hospice payment reform occurring, where they're evaluating our current per diem payment structure, and they're looking at maybe changing that and tweaking that a little bit to save, mainly to save Medicare money and provide reimbursement to hospices at the beginning, more heavily at the beginning of care and at the end of care when care needs of the patients tend to be higher. So just to kind of review, how can hospice make a difference? Well, we have an expertise in pain and symptom management. We provide the psychosocial and spiritual intervention and care. There's the bereavement care and the grief support, coordinating everything that is happening at the end of life, planning for funeral, planning and helping in the development and creation of advance directives for that patient, and also negotiating some of the ethical issues that may be encountered as a result of what that patient family or a patient without a family is going through. So who benefits and how? Let's look at the stakeholder benefits first for the patient. Well, they receive the care that they want at home. They receive it where they want it, and they receive it when they need it. Patients and families satisfaction surveys that are done show that there's a marked improvement for patients accessing formal end-of-life care. In other words, pain and symptom management occurs. They have psychosocial spiritual support. There's self-directed care, and as a result of the healing that can occur at this time, there's closure that occurs that brings a sense of relief for the patient and for the family as well.